About a year ago, the American Medical Association pulled together a conference on this issue, and they issued a paper called Physician Burnout is a Public Health Crisis. So I read the article, but I also thought it was like reading the comments. So one of the, I'll read two sets of comments. It said, first of all, and it was 10 CEOs like us kind of on the paper. And one comment says, why would you ever listen to a CEO? All they do is talk to each other and the policy people. They know nothing about patient care. So that kind of sets the bar there and so forth. And the second one was from somebody who wrote in, I'll just read this directly. It says, if you're serious about reversing physician burnout, you can take the following steps. 1, stop physician order entry requirements in hospitals. Okay? 2, stop all patient satisfaction surveys. 3, call for an end to the unethical human experiment called MACRA. 4, stop collecting bonuses for meaningful use. And 5, cancel contracts with every insurance company that doesn't respect physicians. So sometimes in these comments, I know when I've written stuff myself, I sometimes, with a bit of dread, look at the comments there and say, okay. And I think in some ways what we want to say here today, and hopefully the bar is not being set too low, just kind of going back to some golden age that never existed, is just not possible at all. And we're not going to go back to a period where there weren't EHRs. But as you think, a lot of the conversation today, and in part yesterday as well, was around issues about electronic records and information. But also, when you think about the last 15, 18 years, part of what was, in some sense, in the last election was, for the average American, the bulk of their compensation increases since the year 2000 has come through healthcare. Not obviously the 1% is fared differently, but the average American making $50,000, $60,000, their compensation increased the last 20 years. And therefore, you have a lot of concern about the share of GDP going to healthcare. And that force and that kind of concern about that is not going to go away anytime in our lifetime. Healthcare is still very much a local business. It's becoming more regional in the case of Nancy's system and mine, but still very much a function of local geography. I was speaking to somebody last night about one way of looking at medical systems. I'm a sports fan, is to look at kind of sports fans. So, for example, living in Philadelphia, if I look at who's a Phillies fan versus a Yankees fan or an Orioles fan, we can tell where the medical referrals are. And that's true around the country. It reflects localities, and political cultures really drive medical cultures as well. So part of what one can do in Denver is much different than what one can do in Philadelphia. I'm a big fan of President Obama, but I knew him in my days at the University of Chicago. But I was very resentful when he was giving a speech pushing the Affordable Care Act. And he was out in one of the ski towns in Colorado saying, this is an ideal health system. I said, everybody's 28-year-old and a fairly wealthy LA person. That's not the American healthcare system. Now, our average patient in Philadelphia is kind of 74 years old, is morbidly obese, has 5 medical conditions, a lot of things going on. And the notion that 28-year-olds are the model for healthcare systems inside the country is just not true in terms of where the costs and real issues are in American healthcare. So how one deals with those kind of variations, we're obviously the land of cheesesteaks versus the land of tofu. So what happens in Philadelphia, what happens in Philadelphia is a little different than what happens out in Pueblo, Colorado, or out in Seattle, Washington. And also, all of us experience, there's been a big consolidation what's going on in all parts of the industry in terms of, you see it not just in hospitals, but in health insurance as well. So the kind of efforts that are going on as big companies consolidate also have big effects on these kind of issues as well. So while we're obviously, and I think appropriately focusing a lot on electronic records and what's really changed with big data over the course of the last few years, these economic forces, in my mind, are equally big drivers of what's going on. And very much what affects people in our kind of roles and physicians is very much driven by the kind of economic constraints. For example, as much as we're all fans of telemedicine, we recently been negotiating with our big Blue Cross plan to do more consults through telemedicine. And they basically gave us a fee for that that was 1/10, 10% of the fee we get for an in-person transaction. Now, even though it was better for the patient, better for us, when you tell a doctor you're going to be paid 10% what you got paid before, it makes a big difference. One of the reasons that Kaiser does as much telemedicine as it does, as you know, Kaiser, by and large, is a prepaid health plan. So they are paid, they're 7,000 a person or 15,000 a family. We still get paid in the East by and large on fee-for-service. So if we tell our doctors, do the right thing, but your income is going to be reduced by 90%, they can't do that. So those kind of issues are not going to go away anytime soon in terms of local variations inside of healthcare. So let me first now then move on to, with that kind of context and so forth, ask both John and Nancy, what are the kind of things you can do? You have this context here of the economics. Everybody feels like somewhat squeezed by healthcare costs. People want to have access to telemedicine. People want what economists call reduce the transaction cost. It's always better to kind of see somebody through telemedicine than pack up mom or your spouse and drive 80 miles from Reading, Pennsylvania down to Philadelphia for Parkinson's. But by and large, what are some of the things we can productively do to reduce some of the burden and stress that's happening to our workforce right now? John, you want to go first?
Sure. Well, oddly enough, I'm not going to focus on the technology. I think the first responsibility is to lead. If you have a fragmented environment, then one of the first measures toward combating that defragmentation is really by invoking a human metaphor. And I'm so glad that Nancy, who like Ralph are two leaders I admire so much, invoked the word resilience, because organizations have a culture. And you can cultivate not only, to use a human metaphor, stress reactions, but also resilience responses. And so cultivating resilience responses, I think, tremendously important. So how we respond and frame. Look, the world is extraordinarily complex. There's an unstable policy environment that leads to a sort of more challenging regulatory environment. There's margin compression leading to financial pressure. There are rational incentives. There is I think, an ethos in healthcare and medicine to do the right thing despite those challenges, which creates a stress reaction and a tension. And many organizational challenges, multi-generationality, et cetera, as that. There's an incredibly sick and increasingly disease-burdened population. And it's so interesting to be an organization spanning 42 markets across the United States. Healthcare is local. Health is local. We have facilities in Utah. The body mass index is almost invariably under 30. We're predominantly a southern company. We actually are more heterogeneous in terms of population than the U.S. at large, and see more uncompensated care in the aggregate than any other organization, and more Medicaid, and the disease burden is staggering. And so to put all this together can obviously lead to an environment of intense stress. So I think our response to that has to be to set a stage where we acknowledge the realities of those myriad challenges, including the technological that I hope we'll speak about later, as a source of excitement, an attachment to mission, an ability to reframe what would otherwise be burden into healthy reactions that breed resilience. So I think part of our obligation is to really simplify the environment and simplify the narrative, and to really provide our organizations with concrete and actionable steps that help to resolve some of these discontinuities. Despite some of the disincentives for telehealth, I think this year we hit our 500,000th telehealth consultation. We found ways to work with outlying hospitals that simultaneously have allowed some critical access hospitals to, frankly, survive while helping to move the tertiary and quaternary need patients to our environments, but interestingly maintain the patient census in those critical access environments. So a sense of excitement in that. I think if that sounds inspirational, I think that's also one of the obligations and the sort of soft arts of the leadership, and that is really connecting individuals to the why. I'm a strong believer in Daniel Kahneman's two-factor theory of motivation. I don't believe you can get there, especially with health professionals, just by incenting behavior. Clearly, there is Maslowian sort of needs, but once those hygiene factors are met, it's the attachment to mission, which actually economic experiments have actually valued and priced. And connecting to mission is critically important. And let me give you both a poignant and tragic example of that. Our organization, we have 18 hospitals in Houston. Hurricane Harvey, we have 62 hospitals in Florida. Hurricane Irma. We had about 13,000 staff. We had about 60,000 visitors and patient families in there, about 80,000 staff caring for those patients. Evacuated 8 hospitals, moved myriad other patients, aircraft on call. What was the aftermath? Well, incredibly important number, 0. 0 patients harmed. And the source of pride in that among staff is really priceless. We had the unfortunate responsibility of caring for the majority of patients in Las Vegas after the shooting. And over 230 patients presented to our Sunrise facility, a massive facility, nearly 300,000 emergency department visits a year, 135 gunshot wounds. The psychological toll on the staff was remarkable, but when I spent time with the chief medical officer, someone, Steve Finn knows well, Jeff Morawski, who's a graduate of the VA as well, and he came to my office and presented me with a Las Vegas Sunrise, Las Vegas Strong shirt. I mean, my eyes just welled up. And I would never want an event like this to ever happen. But to me, it was just an absolute object lesson in the importance of connecting to the why, because it transcends so much of the garbage and the noise that's the environment and allowed people to attach to signal. I think this is an opportunity where creativity can let us move forward. I've heard a lot of talk about the challenge of performance measures. They're very compressed, but frankly, there aren't a lot of new measures in the environment, which is why they're compressed. And so there's some consolidation there, some breathing room for some opportunity to think forward and proactively. I'm actually pretty excited about turbulence, rather than it being exclusively a negative disruptor. And don't get me wrong, there are many things that are absolutely negative, but it's also the catalyst for productive and constructive change. Certainly, I think when Ken Kaiser and I and folks like Steve Finn and others were thinking about VA's transformation in the late 90s and early 2000s, the opportunity for that occurred by virtue of the turbulence that had come before. And so I hope we will grasp onto this, not only in terms of the oppressive aspects, but also in terms of the liberating aspects. And I feel fairly comfortable my two colleagues, see the opportunity to use those tools in this kind of environment, particularly as incoming chair of the American Hospital Association.
I just think we should take a minute and maybe all collectively thank HCA, because John's right. When you look at where the floods were, what happened in Las Vegas, HCA hospitals took care of most of those patients in a remarkable way. And while I think we all are at our best when things are worse.
Very kind, thank you. Very kind, thank you.
And I think perhaps we can't forget what's happening now. So what's the aftermath, sort of the PTSD that I'm afraid some of our caregivers in hospitals that have been harmed either by natural events or by the fires in California or what have you. So we can't forget, especially during this holiday season. Yesterday we sent two flats, I don't know what they're called, those big trucks, to Houston with gifts for the children of the caregivers, because those are sort of the forgotten people right now. So I think we can't forget, but it's a good way to say we are at our best when things are at their worst. And in today's world, where I think there's a lack of or a decreasing respect for caregivers and for hospitals, a place that once stood as the safety net for all, we have to remember that we're there and we're always there 24/7. And we need to share that information, I think, and that's something the American Hospital Association is talking about. And as we're changing the concept of the H, what's a hospital? It doesn't matter. The H still stands for hope. What I find surprising, and maybe I'm just bearing my soul a little bit here, but in the last year, and maybe in the last 6 months, I'm finding CEOs and physicians and nurses talking more together than perhaps ever before, and truly trying to understand what it means to be a team. And we're hearing words that I just haven't heard before in that context, like the word hope, like connect to mission, but it's really connect to purpose. What are we about and why are we doing what we do? And when the mission and the purpose are not in conflict, I think people do rally. And so John just said actionable steps. And gosh, we, as administrators, we're always doing strategic plans and financial plans and all of that. And too often, those strategic plans are something to show off to somebody and go into the bookshelf. we just finished a year of involving a lot of people in some strategic planning, came out with a very thin document. People love it. It's like, I know what I'm supposed to do. There's an expectation, and it takes away some of that noise, and it allows for innovation and creativity. So if you're focused in these areas for our organization, then you're doing the right thing. The other thing is, I find the whole care team, administrators, physicians, nurses, others, like teaching. They like thinking about the next generation. And so being very focused on medical students, graduate medical education, nursing students, and coordinating them within the team has been a source of resilience for our caregivers. The other part is the economic health. So I'll talk a little bit about CRI and what we've done, and that is we've announced an innovation district. So it's sort of anchored with a health sciences and technology district along this innovation corridor and a creativity district. And so together we're putting education, research, clinical care with the Fine Arts Center, with the Historical Society, and then coordinating that out to look at areas where health outcomes are poor. So I'll give you one example. Our main hospital is in a zip code in which they have the poorest health outcomes in the state of Virginia. Well, what does that say to me? That says we're totally failing in our mission. If our mission is to improve health, and we're not doing it in our own backyard, what's wrong with that? And so a whole team's now focused on 2 zip codes in our area, and having a lot of fun working with designing, first of all, working in an elementary school, but now designing and building a new elementary school, working in areas where there's a food desert, taking a food truck, but this isn't something we just hand off to, to somebody else. It's our actual caregivers getting into the communities and trying to understand what's different, what a multicultural, multi-generational region looks like, and how do we affect change in those regions. And that's created some excitement among our whole organization. We feel like we're doing the right thing, connecting back to purpose.
Yeah. Let me just add to that. And one of the things we're still fortunate enough to have is the trust of the American public. When you look at the Gallup surveys and the ones from the University of Chicago, and look at the trust in professions, nurses are still the most trusted profession. In the last 10 years, they've kind of surpassed physicians on that. We could talk more about why that's happened. But nurses there's about 85% trust in nurses. I think physicians and pharmacists are in the high 60s. Elected officials, as you may know, are at 10%, down there with funeral parlor directors and roach inspectors. So they are not trusted very much by the American population. So we have to maintain that trust. But I think part of the theme we heard from John and Nancy today, and we can't go back to a golden age that never existed, but we have to think of all of us as members of complex organizations, but then start treating ourselves as members of those organizations. And in addition to our professional standing and qualifications, how do you treat people as members of those organizations, whether it's HCA, Penn, or Korean? So obviously that focus on a team that you've heard today is a critical focus. Most people at work connect to kind of 7, 10 people. And so even though we may have hundreds of thousands of employees or 30, 40,000 like we do, people connect to 7, 10 people, and how to create that kind of team environment in your organization so they can both be part of a broader whole, but also connect to the people around them is a critical part of creating. There's a reason that the church and the military and other organizations organize that way around parishes and platoons and those kind of teams. Secondly, in a complex world, you constantly have to train. One of the things I'm proud of both in my time at Penn and my prior experience both in University of Chicago and then prior to that in the Commonwealth of Massachusetts, is enormous resources to training. We have our internal training academy. We train everybody. My phrase is, if Roger Federer can have a coach after 18 titles, everybody can have a coach. So you coach everybody. And you constantly keep reminding people, whether it's EHRs or payment systems, whatever, you got to coach people. You can't assume that these things come in from CMS or Blue Cross or from wherever they're coming from ECRI, and they're automatically self-executing. So constantly train people over and over again and try to figure out how to create enough resources inside the organization to train over and over again on it. So whether it's putting in Epic or a new set of payment rules, MIPS, MAC, or whatever it is, figure out how to train people on it. From the people who are the doctors to the people who park your car. Train everybody on what you want to do and just make that a... Obviously, as you've heard from psychologists, you have to listen to people. People are much more engaged when you listen. And you have to be in an environment where everybody gets to participate. You know, and you know, I think one of the modern arguments for diversity the last 10, 20 years is people look at things in different ways. You know, we've learned that either from our moms or from psychologists. You learn somewhere along the way. You know, the old phrase of, you know, kind of, you know, you believe what you see. I think by and large in our modern climate now, we see what we believe. You know, we come there with preconceptions. So having an atmosphere in which you put people of different skills, doctors, nurses, pharmacists, and also we use creative designers and engineers and people from our design school as part of psychologists, social workers as part of teams. So as you look at issues, you come to see it from different perspectives. By and large, as professionals, we're trained to look at the world in a certain way. And to try to get people to come in and say, how do I as a patient experience this, as opposed to how as a professional experience this, is a critical part of what we have to teach all our kind of organizations. So have teams that come there with quote-unquote different lenses and kind of share those kind of learnings in a respectful way with each other. I think it's a good way to deal with all the kind of complexity that we're dealing with. Constantly focus on innovation as well. I mean, innovation is not going to go away. You can't go back to some age that never existed. So figure out how to bring innovation into your organization. We've invested in a healthcare innovation center, but that is staffed not just by doctors and nurses, but as I mentioned earlier, by epidemiologists and by creative designers, by engineers, by people who come to it from social sciences as well as the medical fields. Now, by and large, understand medicine these days, we all know there's so many things that come from the underlying conditions that the population has, they're not just medical conditions. So therefore, you have to have social scientists part of your caregiving team. Whether they're called social workers or whether they're called psychologists, have them as part of the care team is a critical part of what we try to do. Now, fortunately, you know, we were recently lucky enough, I don't know exactly how we got this, but we were just rated by Forbes as the 7th best employer in the country. You know, this is across all employers and not just healthcare, so I was kind of surprised because we didn't even apply for it. So we're asking ourselves, how did we get there? And I think the learning that we've had is this kind of commitment to having teams as part of the learning environment and constantly reinforcing over and over that you're part of a team. Obviously, as you heard earlier in the day and yesterday, there's compromises you have to make as a member of a team. And if you're used to always being in charge, it's a difficult time to be in healthcare. So the question now is how you can both be respectful to each of the professional backgrounds that we have, at the same time be a member of a team. That's the way it's going to go in the future. Let me switch a little bit, and before we invite questions from the audience. You know, we obviously, you know, we go back to Peter Drucker, and he says the hospital is the most complex social institution in America. And we are complex places. John and Nancy, are there learnings you think we could apply from other sectors of the economy and other industries that would be more relevant than perhaps we sometimes think they are to healthcare? For example, are there any you'd willing to share where you've learned from other settings that are applicable to healthcare? And then again, we'll invite queries and comments from all of you in a moment.
Sure. Well, this isn't all that new concept, but is rare, frankly, in most hospitals across the country, and that's the notion of simulation. So, you know, I flew here. It would have been very disturbing to me if I thought my pilot learned to fly while he was flying. And gave this. I was speaking in Taipei a couple weeks ago, and I gave this example of being. I'm a nurse. When I went to nursing school, we first practiced on giving injections on an orange, and then we practiced on each other, and then we actually saw a patient. Well, I guess that's better than first practicing on a patient. But you know, the first time I ever gave an enema, the first time I ever saw an enema was when I was actually giving it to a patient. I think we can do better than that. And simulation is something that is common in most industries, and certainly in the airline industry and the nuclear industry. And so we're very much relying on simulation now, and we've hired 3 human factors experts to focus our simulation and really connect what's happening with the human and a machine, and now tied to that purchasing department, because they've all been separated in the past. So purchasing buys something, we implement it, doesn't work, and we kind of go around in a circle. So I think that's one really good example. The other one, and certainly John may want to talk more about this as well, is the notion of a high reliability organization. And again, the airline industry, the nuclear industry must be highly reliable, and we are not. And so I think learning from other industries is very important. I have to admit, I scratch my head a little bit, though, when we hear things like, well, what if Disney ran your hospital phenomena? It's much more complicated than that.
I think that's a great note to end, is that, or to begin my comments from, is that there are many things in other industries, but at the end of the day, we have to not only be high reliability and quickly adaptive, but it's a high-touch endeavor. While certainly there's virtualization of some things through telehealth, as we've heard about, while there are changes to different settings of care, it's interesting. We received a comment from somebody, and our organization responded to come with us and see the patients in the hospital. And you really see the nature of the disease burden in our society today. But I'm going to take a look at the information science, data science in particular. Obviously, it's been disruptive. Amazon in the retail space, Salesforce and customer relationship management, self-driving cars, Uberization, displacement of universities with virtualization. But how do you actually do that and also not only make it high reliability, as you might argue these entities are at a transactional level, they're pretty adaptive, but what about the touch piece? I think that's where we have a set of opportunities for healthcare in terms of tapping into that data exhaust. That's the inevitable byproduct of the care we're privileged to offer. I mentioned that one of the frustrations is that clinicians don't feel today that they get the yield from all the effort they provide in terms of entering data. If that's one set of challenges, the other is we're in a very tech-centric environment, yet our technologies are not interoperable. So I can't resist a plug to my colleague Kelly Aldridge here from the Center for Medical Interoperability that's bringing providers together to try to eradicate that lapse of being able to use the byproduct, the data exhaust, in terms of personalizing and improving systems and care. Let me give you some examples of how then data can serve as the fuel and the glue for addressing some of these workforce issues in terms of workflow, workarounds, and overwork. And I think I'll offer 3 here. And I just note that with interoperability, it's not only the opportunity within an entity that is a system like ours, but the opportunity for collaboration among other systems. And certainly can't help but look at Joe Selby here and think of the great work he's doing with PCORI and PCORNet in terms of bringing together disparate information sets. Certainly FDA-sponsored Sentinel and Mini-Sentinel bring together disparate information environments. And so the scale of learning is really unprecedented, and this is an exciting opportunity. So let me talk about the impact on workforce through 3 examples. First, what if? Nancy, as a nurse, I know as a clinician leader that one of the things our staff hate are call-offs or call-ons. I mean, how would you feel, those of you who aren't nurses, if in your work environment you showed up at work and said, I'm sorry, we don't have as many patients as we thought we might have, you can go home, you've totally disrupted. Or you're supposed to get your kid up from school and say, you're going to need to stay and work extra hours because we have high patient demand. Well, this is incredibly frustrating. What if you could use data science to predict surges in the emergency department? What if you could actually optimize the skill set of the nurses, the educational experiences, et cetera, to the acuity of the patients who are actually on a particular unit? What if you could actually predict the staffing ahead of the shift rather than at the time of the shift? Well, this is one of the things that we're using our data science to drive as the product of multiple systems. Let me give you a second example of changing work. So we have 306 cancer patient navigators. I really fundamentally don't like the concept of a navigator because it points to the underlying fragmentation or the non-systemness when you need to apply a human to fix it. Well, these 306 individuals up to last year spent 74% of their time actually finding cancer patients to help them navigate the path through our care. Well, that's great when they were there, but gosh, that only left 26% of their time to actually care for patients. Well, what if you could actually use machine learning, artificial intelligence, natural language processing to automatically identify those patients? Well, in fact, we do today. We'll be presenting that information tomorrow at the National Academy of Medicine. And in fact, now those same individuals spend less than 20% of their time actually detecting the patients. They spend over 75% of their time caring for the patients and helping them through a journey inside of our system and outside of our system, given the fluid boundaries of healthcare. But it changes the process. And, oh yeah, by the way, all of us in healthcare who have hospitals are required to participate in the cancer registry. What if, instead of having humans detect cases, you could actually automate the process for making sure those registries are fully populated, accurately populated, and find an efficiency and an improvement in that. And then finally, what would the ideal clinician be? Well, if you're in the hospital and let's say you're at risk for a condition called sepsis, which I know is total overwhelming infection, but it's really kind of total body failure. It's the 11th cause of death in the country, number 9 in hospitals, number 3 in all ICUs, and number 1 in non-cardiac ICUs. And oh, by the way, every hour of earlier detection equates to 17% greater survival. Your ideal clinician would be someone who's looking at all the data, all the time, and acting on it at the moment those data are created. Oh yeah, and by the way, they'd be able to deal with all the different relationships of the data simultaneously. Did you know in the average ICU there are about 1,000 data points created every hour? There are about 300 orders in operation. Now just hold that number, 1,300, 1,000 plus 3, compare it to another number, 7. Psychometricists know, Bill Stead in particular demonstrated we can handle about 7 numbers. The old 7-digit telephone number was based on that. 7 factorial, 7 times 6 times 5, et cetera, is 5,040. The human brain is pretty good, 5,040 relationship. Oh, 1,300 factorial? Anyone care to guess? 10 to, lots of zillions. Yeah, bigger than zillions is actually 10 to the 35th, more than the number of believed to be infinite particles in the universe. I can't handle that number. And I would like some help. And by virtue of using this technology, 2 things. One, we've improved our sepsis detection from already better than industry averages to be 12 to 18 hours earlier just by detection, not by prediction. And oh yeah, efficiency-wise, the specificity is actually 50% better than humans. Second derivative in terms of supporting workflow and efficiency is that I wish I could say that all units, all nursing units, all care units, all hospitals are created equally and equally excellent. But that's not the case. And I didn't start as an expert. I started as a novice. I wouldn't have been able to recognize that patient. So what if you could arm those care providers with the intelligence to recognize and tee up a question for them? Well, that's where I see the intersection of data science and Ralph, to your question, the real opportunity to learn from other industries that are using that to support efficiency, workflow, and I can't tell you again, the pride of a job well done, connecting back to mission and purpose and why, and building resilience in a turbulent environment.
That's great.
Thanks.
Please.
I'm Dr. Caroline Poplin, a primary care provider. That puts me at the other end of the system. I'm concerned, I'm going to start where you started with fragmentation. And from where I sit, the answer to fragmentation is an interoperable medical record. And what needs to be in it is stuff about the patient. So my mother, she's 94. I just came back last night from Boston. She's pretty healthy, but she fractured her hip a couple of years ago, and she had a small heart attack a couple months ago. And she's flipping between hospitals. The Needham, Massachusetts emergency room has one system. It's part of the Beth Israel Deaconess system, but they don't have the lab results. So she had to have her labs drawn 4 hours after she had them drawn in the emergency room. For the heart attack, they took her to Newton Wellesley. That's part of Partners. and that's a different system, and they don't have the records. Now, this is the most sophisticated medical place in the country. Those records should be interoperable, and that's what people expect. They expect it's like the ATM card. You can use it here, you can use it in Europe. Here, you can't go from one hospital to the next. It's not about the system. A patient doesn't want a system. A patient wants someone who cares about them. That's the beginning of each one of these conferences that I've gone to. And 3 years ago, there was a speaker who was talking all about the system and the team. A patient doesn't want a team. They want a person who cares about them, preferably just one, and the same one. And you haven't addressed that. In fact, you haven't mentioned patients or customers at all. So what do you think?
John, Nancy? Okay.
Well, first of all, I think you're not here, you're here, you're at the top of the heap.
Doesn't feel like it.
And I think that's a really important comment, and I tell you, we completely agree with the issue of interoperability, and I'm on the board of the center. We think it's exactly how it ought to be. There's a lot of barriers to that right now, but a tremendous focus on it. And I think at the end of the day, it isn't about one system talking to another system and so on. It's you owning your medical record and being able to utilize it any place, regardless of where you are.
I think we actually violently agree. I never said a patient wants a system. I did say a patient wants systemness. When my 93-year-old father actually needs care in a couple of environments, I want it to connect. That's why I think for the patient interest, nothing is better served than the ability to have that last mile interoperability.
Not last mile, first mile.
I'm sorry?
First mile, not last mile.
Well, okay. The industry term is last mile, but it's the ability for your mother to connect her records at two disparate institutions so that they can talk to each other, and whomever is caring for her at any moment actually can connect. If I could do two things in the remainder of my career, it would be support interoperability and improve hand hygiene.
Let me, I heard one of these meetings somebody say that whenever he heard John Perlin speak, his SAT score went up. So, I agree with that. My SAT score has gone up. But I do want to say something, perhaps in mild disagreement. And that is, I think one of the central themes that we are losing is sense of mission and professionalism. With all the data and all the, talk about all the mechanical things and data, I think the individual physician is beginning to lose a sense of mission. And partly because of that, it's not completely divorced. And as you said, you can regain the sense of mission perhaps in part by that. But just to give an example, money does not prevent burnout. It may change behavior somewhat, but I'm a cardiologist. I know many burnt-out cardiologists at age, started happening at age 45 or 50. Cardiac surgeons who make more than anybody burn out just as much as anybody else. I've seen it many times with very pathologic, by the way, consequences. So how do we... And just one more point. The VA, I think, has maintained itself through many struggles with its very narrow sense of mission. And I felt that very strongly in the 8 years I was in the VA. So how do we do that amidst all of this and perhaps preserve our professions of medicine and nursing for the future, which is going to be crucial to do the things that this last questionnaire asked?
Well, John, and then John will go, then I'll go. So.
Well, thanks, Joel. I think that's incredibly important. And I started with that, and that's why I really agree that why the patient is so central. That's why we're there. I said connect to why. That is the why. At VA, it was really clear. I think you remember from my tenure that, I think the mantra that gave rise to VA from Lincoln, care for those who shall have borne the battle, really makes very clear what mission is. And I think it's unfortunate when we are reductionistic and mechanistic because, in fact, it's all about mission. And, in fact, the irony is if you want to be even sort of more reductionistic and mechanistic about it. As I mentioned, the economic and psychological theory would suggest that if you connect to mission, there's actually value there. So it's really, I think, fundamentally important. Beyond all that, I know when you find, and this is why I mentioned the Las Vegas and the hurricanes, is that these were times where people were at their best during the worst, to use Nancy's words. It was a reminder of why they were there. It cut through the noise of the moment and forcefully reconnected to mission, an environment that is so noisy with distractions at every level, particularly in healthcare. But I think this is an opportunity, and as you see the sort of ascendancy of notions like quadruple aim, that in addition to health experience and cost, focus on the care providers. I think one of the opportunities to build that resilience is through that connection to missions. I couldn't agree with you more that there's been damage to that, but I also see that as antidote and opportunity.
I'll just briefly state one has to work at it. I mean, just we can list EHRs and payment pressures and value and all that kind of stuff, but if you don't work at these kind of issues, it's not going to happen automatically. So, as I said earlier, increasingly we're in big complex organizations. The complex organizations have to take these issues on, as opposed to just thinking they automatically solve themselves. So, and obviously it's not just physicians. Physicians are the ones most discussed these days. The same issues are there, nurses, pharmacists, and so on. So in some ways, all of us organizations really have to work at it. It's not going to happen magically.
Yeah, I would just agree. Ralph said several times there really wasn't ever a golden age, but that doesn't mean we sweep under the table that there's not a golden age, and that people are genuinely hurting right now, and our caregivers, particularly our physicians, are feeling different about what they're doing and the respect they're receiving. And I think we do have to wrap ourselves around that. We have to lead in that space and not pretend like it doesn't happen.
Next.
Hi, Allison Russo from Kennel and Associates. As I listen throughout this conference, we've talked about many things. We've talked about the payment piece and looking at these alternative payment models. We've talked about the innovation piece, whether we're talking about new technologies or innovations that are making things more efficient. The piece that we're not talking about, I think, and we've also talked about the population health piece and those social determinants of healthcare and how important that is. But the piece that we're not talking about are the prices. And in the words of the late health economist Uwe Reinhardt, it's the prices, stupid. And I don't want this to sound accusatory, and this I may not be popular in this audience in particular of providers talking about this, but the responsibility of making these prices more transparent and less variable, even when we look at the prices on a regional level and the amount of variability that we have, the opaqueness of the prices, because from, again, going back to the patient, from the patient perspective, the biggest hindrance to healthcare is the affordability of healthcare. And what role as providers, especially large health systems and hospitals, do you have in that conversation? And I would also bring up, there's a very interesting piece that Sarah Cliff, the health journalist from Vox News, has been working on, looking at ER bills and the curious case of the $629 Band-Aid. That's a huge issue, and I don't think that we can have this conversation. It feels like we're just nibbling around the edges without talking about the price piece.
Let me take a crack at that. There's many prices in American healthcare, there's a Medicaid price, there's a Medicare price, there's a Blue Cross price, an Aetna price, and so forth. So even if one comes into our hospital, what's the price? Depends on your insurance, and depends on what narrow network you're in, and so forth. So it may sound offensive, but there's not a single price the way that it might be on a car or a TV and so forth. And unfortunately, unlike some European systems and so forth, where you have single payers, we don't have that, and we're never going to have that, despite Senator Sanders. We're too varied a country. So there's an enormous difference in prices. Now, nobody's going to, yesterday on NPR, they were talking about somebody who brought their daughter in, all of a sudden had the ears pierced for $1,800. Obviously, nobody's going to defend that kind of stuff, or the $600 Band-Aid. My sense is that there's too much asymmetry when you're in the middle of an open heart procedure, you're not going to start negotiating prices. So I frankly think, I would disagree. I think the prices being known to patients aren't going to make that much of a difference. Obviously, on elective stuff, you'll negotiate your MRI and colonoscopy and so forth, but most of healthcare is people with 6 multiple conditions, 74 years old and so forth. It's not a time to negotiate prices. So I'd probably be more in favor, compared to the rest of my colleagues in the industry, to have more national price setting a la Medicare, rather than to think that the consumer is really going to have a lot of say in negotiating their care in the middle of a crisis. But that's not popular in my field either. But I think I would predict next 10, 20 years, we'll go much more as we have been in the last 10, 20 to kind of national prices set by Medicare, as opposed to the variation we have right now. I think the sense that in the middle of an acute episode, you're going to start negotiating your emergency room is just, it's just not going to happen.
As the chair-elect of the American Hospital Association, I chaired a committee, brand new committee. We decided to focus on innovation. That translated very quickly to affordability. And there really is something wrong in our country when the #1 cause of bankruptcy is our healthcare cost. It's so not simple. It's very complicated. And I think we thought a year ago when we started this committee, okay, we'll focus on it, we'll get some good ideas, we'll pump them out to the nation, and quickly decided this is a multi-year, multifaceted issue that we must address. We're part of the problem, and we can be part of the solution, but of course not part of the whole piece of it. When you compare us, for instance, to other countries, we talk about how our health outcomes are not as good as some of the westernized countries. At the same time, we don't talk about the funding of public health and social health services. So we're not ever comparing apples to oranges. But, and I'll draw it down to a really simple example. So a $600 Band-Aid does sound crazy, but we can't charge for an electronic health record. We can't charge for nurses' time at the bedside. We can't charge for so much. So you pile on charges at one hospital onto a Band-Aid because you can charge for that. And you can get reimbursed for that. Where at the next hospital you pile it onto, IV. It's so complicated. And talk about fragmentation. So to fix pricing is not simple. And then every insurer pays us differently and pays us differently for every single entity. So when you're creating your yearly financials, you've actually got a huge book that you go through to try to figure out how can you predict what services you're going to have and what you're going to get paid for those services. So I just say it's, it feels defensive. It shouldn't be. We need to open this up. We need to talk about it. We need to have a national conversation about it and a local conversation and figure out where are the sources that can come together and really address affordability and access to quality care in this country.
We have 2 minutes, so we're going to squeeze 3 questions and answers into 2 minutes. Sorry, the fast rapid fire, but since you were up there, please.
I'll be very quick. I want to make proffer a public apology and make one quick comment. And the apology is that in that figure I showed earlier with the performance metrics, I egregiously failed to acknowledge Dr. Perlin's work at that time as the Chief Quality and Performance Officer, who really drove that work. And it was essentially 5 a.m. my time, Seattle, so perhaps I'd be forgiven for making that error. The second thing is they referred back to the session 2 years ago here, and one of the sort of pithy little statements that I took away from that was what Gordy Schiff said, is that there aren't complex patients, there are only complex systems.
Thank you. Yes? Okay.
Kristen Miller, the National Center for Human Factors in Healthcare at MedStar Health. My research is in clinical decision-making and informatics, namely in sepsis. And as engineers, I think we're often guilty of innovating in areas that don't need innovation, especially when we're not embedded with clinicians. So as a researcher, I'm curious, as presidents and CEOs, what do you see as the biggest areas where we need to focus for innovation?
Well, this is a target-rich environment. Actually, if
Where
you
do we
just looked
start?
at the top diagnoses and the disease burden, I think those are a number. The first question, I think is really one, how do you create systems given the fragmentation? I particularly am very interested in, the nexus between care and health, and I think that's an area where, information revolution needs to occur. We need a meaningful use for the public health environment as well. But we don't have enough data scientists in the country to actually support the needs in healthcare now, but the top areas of patient harm, risk, quality are many of the opportunities.
I think I'll be just real discreet. You're in human factors. Two things. One is, how do people actually access care? It's so complicated, and what do we do as humans to get in the way of actually people accessing our care? And the other is how to make it easier for staff to deliver care. So really focus on staff, the staff writ large, the whole team.
Les? Yes.
Virginia Saba, I have just one question about the patient owning their own record. Why can't they have the data on their record when they go to the hospital, get their results, take it home, and when they have to go to another hospital, they have all their material in one place?
Of course. I talk about this, and I'll have to admit that, I'll be real quick, Ralph, but it is your information, it's not my information, and that you have a right to it. And for some of us who are on an electronic health record and have something called My Chart, or depends on what service you use, you have 24/7 access to your full health record. And it's sort of like, what a concept. But I'll give you this example of how hard that is for us to change. So my husband, I was taking his blood pressure, and I have this little machine that I'm looking at, and he turned it towards him, and I turned it towards me, and he turned it towards him, and I turned it towards me, and he said, I want to see too. I was all about giving him that information, but I wanted to process it first before I showed it to him, and that's just the dilemma we face. I think as clinicians, we're not socialized yet to share information readily. But you're totally right. You should have access 24/7 to your data, and whether you pull it off or you have it electronically.
Well, let me thank John and Nancy again, and also to Jeff and our colleagues for inviting us to be with you here today.
You guys are great. Hopefully my recipes are that too.
I don't know.